hi, as Ross said, I'm Sarah. I'm one of the consultant scientists around. Just coming to the end of my training now. I'm based in London and Colindale. Before I start, what I will say is if anyone's got any questions or anything at any point, please shout. I can't actually see the Teams thing, so if you put your hands up, I'm not going to have any idea you submit, so I'm really sorry. But I'm more than happy to take questions. Just go over in more detail or whatever, then please do also vocalise it in some way if that's all right, because I can't see. So Ralph asked if I could give some sort of presentation around transfusion support, particularly for hemoglobinopathy sickle patients. So I put some slides together. If there's anything that you think we've missed and we want to discuss, feel free to ask at the end. And as I say, hopefully this has got the right level for you all. So just a brief kind of overview of what we're going to cover. So we're going to look at the background of why of what we're doing and why we worry, particularly around transfusing these patients. Providing blood and how to conquer the difficulties in providing blood. So I think that's probably of some particular interest to members of this group. And then a couple of difficult case studies that I've kind of come across on call, which I thought there were quite a few interesting learning points that maybe we can discuss. So a bit of background. So obviously I'm probably teaching you all to suck eggs, so I'm really sorry. But hemoglobinopathy patients often require frequent and long-term transfusion support. So it may be regular top-ups, it may be they need frequent exchange transfusions. There's obviously lots of hemoglobinopathy patients that don't require any transfusion, but there are equally a cohort of people who do. And a significant proportion of donated blood goes to these kind of patients. So if you ever look at where blood goes from NHSBT, predominantly it's haematology. And then if you break that down, there's quite a significant proportion that goes to sickle patients. And this is obviously, the more blood you have, the more likely you are to make an antibody. So this cohort of people often develop better antibodies, which can complicate transfusion requirements and make it quite difficult. And I think it's particularly important that at this point we think about our actual population. So the hemoglobinopathy population are obviously of one ethnicity, and our donor population are predominantly white Caucasian. So there is discrepancies there, which automatically kind of potentially increases the likelihood of you making antibodies, etc., because of mismatches. So what do we do to try and improve our transfusion in this cohort of patients? So we do things routinely, and it's in the guidelines that we do it day to day, as do NHSBT. So we immediately try and minimise any immunisation by providing ABO, full RH and K matched blood to all hemoglobinopathy patients, and that should be standard care across the UK. That's not necessarily standard care across the world, so different countries have different approaches to that. So some countries apply the same principle, other countries don't, and that can often cause us problems, particularly for patients that kind of come from a different country where they've been treated historically and then come to the UK for treatment, and they may not have had RH and K matched blood, for example, and that may be why they've made that initial antibody. So it's really important to think about what we're doing and when to do it. And I think a key home message for me is actually, if we look at some of the data that we get for this cohort of patients who do make antibodies, sometimes they've made an antibody because they've gone into A&E, for example, and had a transfusion, but no one's highlighted that they're a hemoglobinopathy patient. And I appreciate that you guys are all going to be experts at filling the forms in, but it's really important that we educate our colleagues to make sure that everyone's on the same page. So we obviously then try and provide what I describe as fresh blood, and I hate that terminology, fresh blood, but we try and have limits. So for exchanging, we look at less than 7 days, if it's a top up, 14 or 10 days, and that's purely and simply based on the fact that the blood in that bag hopefully is fresher and younger and will last longer, and therefore the longer intervals between transfusion. I'm not sure it's particularly evidence driven or if it's just more common sense, but it's definitely something we try to apply. But again, we know that there are occasions where it's not possible to meet that requirement, and we may have to forego that. The other thing that we do, which you probably aren't necessarily aware of in the transfusion labs in particular, is we tend to provide units which are of a larger volume. So a bag of blood has a kind of a range of volumes, anywhere from about 270 mils up to about 350 odd. So by giving the larger volume bags, you hopefully have to give less, particularly important if you're thinking of an exchange transfusion, where you might want litres of blood. The more blood in that single bag, the less total number of bags you're going to need, which reduces your exposure to donors. So by doing that, hopefully you're going to prevent immunisation. So it's definitely important to think about that, and the labs automatically do that anyway. And then obviously from a clinical perspective, we try and optimise our transfusion intervals. So So making sure that we can get the maximum amount of time between transfusions, because obviously the less we transfuse, the less likely there is to be any untoward event. We do quite a lot anyway, routinely. So why are we particularly worried about transfusing hemoglobinopathy patients? Anyone who works in haematology transfuses people quite frequently, but why is there this big concern in hemoglobinopathy patients? Well, we know about 30% roughly, give or take, of chronically transfused patients will go on to develop red cell antibodies, which is obviously quite a high percentage. So 1 in 3 of our patients is probably going to have, at some point, make an antibody. Typically, if a patient's going to make an antibody, it's going to be to an RH, so C, little c, big E, little e, or D antigen, or to the KEL or big K antigen. So by matching for the RH and K, which we do routinely in this cohort of patients, we're hoping to avoid that initial sensitization. Because if we can avoid that initial sensitization, it's also a well-known fact that for anybody who goes on to make an antibody, there is an increased risk that they'll make a secondary, third, etc. antibody. So by preventing that primary immunisation, we hope to prevent immunisation full stop. Now we know that doesn't work, because we know that there's sickle patients out there, for example, who have made antibodies, despite the fact they've had RH and K matched blood their whole lives, and they've still gone on to make another antibody. But it does prevent a percentage of those patients making antibodies, so it's really, really worthwhile doing. So this is our biggest concern. Now, as I've said and already alluded to, in the UK, our cohort of donors are white Caucasian, which means they're going to have a white Caucasian phenotype. But this particular patient group that we're transfusing to is obviously not white Caucasian, and there are discrepancies between different ethnicities around blood groups. And this is sometimes where we get these antibodies from developing, and because we're not able to get the perfect match. And I think, you know, in an ideal world, we would try and match perfectly, but it doesn't happen. So what happens when they do make an antibody? What kind of things do we think about? So when they've made an antibody, what kind of problems does that cause us? So we know that anybody who's got an antibody, it causes major issues in terms of transfusion. Was that a question, or was that just somebody joining? No? Okay. So we know if you have an antibody, it complicates the transfusion testing required. So for a high percentage of hospital patients, hopefully within our transfusion laboratories, they're going to have electronic issues. So we're going to be able to pop them on a machine, do all of our testing that we would do, which we'll talk about in a bit. And then blood can be issued out without any real delay. And that process is quite quick. As soon as a patient makes an antibody, that process becomes a lot longer and takes a lot more manual intervention. And therefore, you know, there's greater risks, but also it's the time it takes. So it's not an off-the-shelf jockey necessarily. So when a patient makes an antibody, they have all of their routine testing, plus we have to then identify the antibody. And the more antibodies you make, the harder it gets to identify them. And we have to be 100% certain that we've identified everything they have got, but also we've identified everything they haven't got. Because the last thing you want to be doing is giving blood that isn't completely suitable to this cohort of people. And that can take quite a lot of time. Now, the picture here that you can see, which if you've ever done any Royal College exams, you'll probably be really, really familiar with. But for those of you who aren't, that's an antibody panel sheet. And it's a bit like a puzzle when we're looking at it. And the idea is that you look at your positive and negative reactions and work out what the patient's reacting to and what they're not reacting to. And from that, you can ascertain what antibodies they've made and what they haven't got there. And that's a really skilled technique. And any of your guys in your blood transfusion labs are really, really good at doing these things. But they're very limited by the resources they've got. So most hospitals will have one, maybe two of these that are slightly different. They've got slightly different expressions of things. And if it has to then go to a referral service such as NHSBT, where we've got a vast number of panels available to us, that obviously adds further delay. So you've got the getting the samples there, and then they're having to go through the system all over again, plus all of the panels, and then getting those results back and or blood back to you guys. So by trying to avoid that antibody, then we're hoping that we can avoid all of those delays. So what can we do from a clinical perspective? So from a clinical perspective, there's a few things that we need to do before we issue out blood or before we think about anything. So I always say clinical history is vital. So one thing that often happens with patients is they might make what looks like an antibody, for example, and it gives we get some sort of reactions. But actually having that clinical history is really important. So particularly for our sickle patients, they have a tendency to go to various different hospitals and different institutes and sometimes different countries. So it's really important that we ask the patient, do you have a history of a red cell antibody? Patients usually have quite a good idea if they've got something. An HSPT, for example, give out cards, which you may or may not have seen. But other hospitals may have sent them away with reports or various other pieces of information, which may be helpful. And also, if you've got a patient who kind of comes into your hospital, and it's probably done in a transfusion laboratory, but it's probably worth you knowing about. There is a national system within the UK called SPICE. So this is an RCI-based system where you can look a patient up and they can see if there's any history of antibodies. So it may very well be, for example, that your patient was in Birmingham and had an episode where they were unwell and required transfusion. So they were seen by our Birmingham RCI laboratory. And that record can then be picked up locally your end. So that can help speed up the process from your hospital, because if you already know what the antibody is, it can help get you blood quicker. So it's just worth knowing about both of those things as well when you're looking after people. So what testing do we provide for sickle patients? We have a couple of things, and there's things that we should do proactively, and there are some things we may do reactively. So proactively, before we commence any transfusion regime or we transfuse a person, hopefully we should have got an ABO group out of them. Ideally 2 samples nowadays, that's what the BSH requirements are. So we've confirmed twice what the group is. And then in a sickle patient, we should tend to do what I call extending phenotyping. So routinely for every patient, we would do ABO and D typing. And that's standard care across the UK, no matter who you are. But for sickle patients, because we know they're going to more than likely require transfusion at some point in their life and potentially have a chronically ongoing transfusion requirement, we tend to do extended phenotyping, sorry. And we'll look at the full RH and K, which can be done by most transfusion laboratories. And then it's recommended that they have a full extended phenotype. Now, by extended phenotype, I mean all of the other blood groups. So looking at the M&S system, the KEL blood group system, the Duffy system, and the KID system. And that gives us an idea of what antibodies they can make. And now the reason we suggest that we do that full phenotype isn't because we're being awkward. Is you kind of get one shot at doing a phenotype. So if a patient's been transfused, we can't do a phenotype at all, because what we'll do is we'll detect the donor cells, so it becomes really complicated. So by doing it up front before they commence any transfusion regime, then we can have a look and see what they can and can't make. And that can really help, particularly if we get a patient with really complex serology, because you can rule out certain antibody specificities just by looking at what they can or can't make. So for example, if we know our patient is positive for, say, FYA, the FYA antigen, then we know they can't make an antibody to that, because we know that people only make allo antibodies to things that they are negative for. Obviously, that doesn't stop them making autoantibodies and things like that. And as haematologists, you've probably experienced autoantibodies, but they're generally not as clinically significant as allos. If for whatever reason our patient has been transfused, so either at our site or at a different site, then there are other technologies we can use. A couple of years ago, I'm sure a lot of your patients have probably underwent this, but there was a mass scheme to try and genotype lots of sickle patients called the HGP project. And that's where we look at the DNA and we go to the genotype of the patient. So we can do this regardless of whether they've been transfused or not. The only contraindications if they've gone through a transplant, just because it can become quite difficult to interpret the results. So we can have a look at an allelic level what they express on their cells, and this is really good. And there are pros and cons to doing phenotype and genotype. And again, I may be teaching you to suck eggs, so I'm really sorry. But phenotype is obviously what's physically on that red cell. So we are looking at a red cell coming in with an antibody and seeing if it's there or not. So you get a yes/no answer. Whereas with our genotype, we're looking at what the patient should have on their red cell. Now, as we know with genotypes, there are always other genes that can interact. So you may have gene A, but if you're lacking gene B, that means gene A isn't exposed, expressed, for example, and that happens with red cells. So we have to interpret our genotypes with caution. And the other thing that genotypes are really good at is picking up these kind of variants. So when we look at a phenotype, for example, it may be that a patient appears completely negative, so that they don't look like they have that antigen on their red cell surface. But actually, when we look at a DNA level, they express most of the gene, maybe a little bit missing, and therefore it's what we describe as a variant. And that's quite common in sickle patients. So if we look at lots of data that's come out of the HDP project, we'll quite often see that there are lots of variants within the RH, the group system, particularly within the hemoglobinopathy patients. And that can cause us quite a lot of issues with transfusing, and I'm going to discuss that in the next slide a little bit. But it is really useful to know. So I think there are pros and cons to both phenotyping and genotyping. I think gold standard in the long run will become genotyping, is my gut feeling, but currently we're still using both in the UK. Hopefully I haven't lost anyone yet with science. So as we've talked about, we tend to RH and K match blood for this cohort of patients for the reasons that we've described below around avoiding immunisation. And if you've got a really easy RH and K type, that's really easy. We can match for these. So this is what we call our shorthand nomenclature. And basically it gives you a list of what we can and can't transfuse across these patients. Now, the problem we then encounter is if you have one of these variants that we've talked about that you can get and that we would detect by the genotype, then what do we give? And then it becomes a bit more complicated, because if you're a variant, that means you don't have either the whole antigen or any of the antigen, depending on how much of a variant you are. So there's a risk that you could make the antibody. And so there's a very complex algorithm that we use in NHSBT, which we can decide which blood would be suitable. So I think if you ever get one of these HDP reports and you're a bit confused by it, A, you're not alone, because they're very detailed reports, but B, you can always have a conversation with any of the NHSBT RCI medics, and there's a combination of consultant haematologists and consultant clinical scientists or consultant clinical scientist trainees who are on call Monday to Friday, and we're always able to advise on what to do. So for a majority of these patients with variants, they'll be quite happy with antigen positive blood, and they probably won't have any issues. There are a small cohort of people who will go on to make an antibody to that bit of the antigen they're missing, and it does cause hemolysis, and it's at those points that we have to think about what we're going to do. And some scenarios it's really easy to resolve. We can find alternatives without causing any problems. Other scenarios it can become a bit more challenging, so it's definitely one that you can discuss with any of us at any point if you needed to. And when we're matching for red cell antigens, we only routinely match for RH and K. Now, there are some hospitals out there who would like to give extended match for everything across the board. So we've got a full phenotype, genotype, why don't we match for everything? And that's a really good question. It's something we'd love to do. And, if we could, it would be great to give fully matched blood, because then your risk of immunisation is incredibly low. The problem is we just wouldn't have the donor population to do so. So, we certainly wouldn't have the U negative donor population, for example, to be able to provide everybody who was U negative blood without an antibody U negative blood. So I think there's long-term gains and aims that we will eventually genotype all of our donor population alongside of our patient population and be able to give fully matched blood, but that's a long way off yet. And there's not really any evidence per se that it's particularly useful other than to prevent immunisation. So hopefully I haven't lost any of you yet. So we've discovered that we've got an antibody, and we've discovered what it is. We know exactly what it is. Where do we get blood from? So I call the difficult to transfuse patients anybody who's got an antibody automatically becomes more challenging, because it's not just ABO and RH and K, which should be easy to obtain. So we've got lots and lots of different alternatives, and I think this is probably an area that's probably quite interesting to most people. So for patients with a single specificity of an antibody, for example, or with kind of I'm going to call them routine antibodies, and that sounds a bit of an odd one, doesn't it? But you know, you're very easy to identify, your JKAs, your JKBs. And we should hopefully be able to get blood straight off the shelf for you. So either your hospital might have antigen negative blood, or worst case scenario, NHSBT and their stock holding units would be able to get you some antigen negative blood. And that's really great. So we'll be able to do our cross matching and get blood out to you, no problems. So what happens when you start to get lots of antibodies, or a single antibody to a high frequency antigen, so one that everyone in the UK or most people in the UK have on their red cells? And where do we get those? Where do we get that blood from? And that automatically starts to cause us a bit of a headache and try and think about things. So we've got three options. We can have a search anywhere and see what we've got. We've got blood centres across the whole of England. Sometimes we're really lucky. You know, I've had scenarios when I've been on call when I have a patient present with a high frequency antibody, and I've been able to pull units off the shelf because they were donated yesterday by a random donor who came in, which is great. That's not going to delay us too much, so we can get blood moved around. We've then got two other options, one of which is what I'm going to call reactive. So we've got a patient who desperately needs a transfusion this second. We genuinely haven't got loads of time to wait. We can stabilise them for, I don't know, the next 6 to 8 hours, but after that point, they're really going to need a transfusion. And then we've got our national frozen blood bank. So NHSBT has a frozen blood bank in Liverpool, and we specifically select blood in that bank that would be rare, or what we deem as rare. So predominantly looking at either multiple antibodies. So if we know we've got a patient, for example, that's got, I don't know, say 6 or 7 antibodies, and it's really difficult to get blood off the shelf, we may have blood frozen. Or if we've got a patient with a high frequency antibody, so an anti-U or an anti-DEFI3, for example, that you quite often see in hemoglobinopathy patients. So we've got blood up there. Now, that's all frozen down, as I say, so it's going to have a time. It's going to take time to defrost that blood. So blood is frozen in glycerol, if anyone is particularly interested. So we have to deglycerize it, and then we suspend it, and then send it down. Now, as I said, that blood bank is in Liverpool, and there is only one of them. They do offer a 24-hour service, but it takes time. So the actual washing of that product and defrosting of it takes about 3 to 4 hours. And then obviously there's a transport time. So realistically, if you want frozen blood and we're in London, for example, it's 8 hours plus. So not ideal. If, on the other hand, we've got a patient that we know is coming in for a particular procedure, and we know it's elective and we know what day it's going to be on, we've got the option to call in donors. So all of those blood bags in the frozen blood bank are from donors that we've got on our panel. And we have a rare donor team in NHSBT who, with sufficient notice, about 4 weeks, give or take, can contact donors, ask them if they would mind coming in for a donation session. We can bleed them and store those units as wet units. So as your standard units that you would see on the shelf for any other kind of transfusion that you were going to use. And that has great advantages. A, we can hold it at NHSBT for you, or B, you can hold it at your hospital if needed, and it's ready to go. There's no defrosting, there's no transport time, etc. So there are pros to that, but obviously that isn't going to work in this emergency situation. But it's useful to know that we can do that, I think, and hopefully if you've got patients who may fit into that category, we can have discussions about it at other HCC meetings. So what do we do if things go wrong? So what do we do if a patient presents with transfusion reaction? So we've done everything in the world that we could. We've given our ABO-RH and K-match, we've given antigen negative for any antibodies, but they still proceed to have a reaction. So obviously we're going to follow all our standard protocols. We've got kind of 2 transfusion reactions that we're thinking about, immediate or acute transfusion reactions and delayed ones. And on both of these, then we should think about performing various screening tests, which we'll talk about next, and looking for the presence of any antibodies that may have caused it, as well as ruling out other causes, and treating the reaction appropriately clinically, obviously from your end. So what do we actually do? If you phone up and say, my patient's had a transfusion reaction, what does the lab actually do? So routinely, hopefully most patients who've had a delayed or acute transfusion reactions should have had a full hemolysis screen. And by that, I mean things like LDH, bilirubin, haptoglobin, blood film, full blood count, potentially a urine dipstick, and then a DAT. And that DAT is a particular bit of interest for transfusion because that's the test that they would do. But they will look at all of the other results too. And then as part of the transfusion workup, you would expect that all of that blood group serology would be reperformed. So we would want to check that the ABO group was what it said it was on the tin, and that there was no antibodies, or whichever antibodies we'd identified were still there. And were there any new ones? That DAT will have been done, and by DAT, just in case you don't understand what I mean, so DAT stands for direct agglutination technique. And that is literally looking for antibodies stuck on the red cell. So if your patient has an antibody and you give them some blood that's got the antigen, what you'll eventually see is that sticks to that red cell. And eventually that's going to get removed from circulation, either intravascularly or extravascularly, depending on the antibody. But what we can do is we can have a look and see if that antibody's got a specificity. So we have a technique called an eluate. And an eluate is basically pulling off that antibody off that red cell and then looking at it to see what it is. We use acid elution in NHSBT. So you put your red cells in a bit of an acidic solution that causes it to unbind. You then quickly neutralise it so you don't destroy your antibodies, and then we can use that liquid to have a look and see what they've made. And that's really helpful, particularly in these cases, because if they have made a new antibody, you may not see it in their plasma because it may be quite low levels, or quite crudely speaking, it's all coating the red cells. But by having a look at what's on the red cells, we can definitely see what's going on. So if we discover there's a new antibody, then we can have a look at, was the blood antigen positive, for example? So we can have a look at historical records, although if you've seen it binding, it's pretty conclusive. And then we can confirm that antibody is an alloantibody. So if we happen to have a pre-transfusion sample, we can do a full phenotype on that patient if they haven't already got one. If not, then we can consider a genotype on them to see if they can make it. So most of the transfusion reactions or hemolytic episodes that we're going to see are going to be what I call delayed, so 10 to 14 days after the transfusion event, because most of the antibodies that cause these reactions are going to be IgG in nature. So they're going to be removed extravascularly and quite often present quite late. And it's usually a patient feels like they haven't had the transfusion, or they've got dark urine, or other kind of symptoms that we're all aware of. It's very rare that we're going to see an acute transfusion reaction from an antibody, with the exception of things like ABO and VEL, because they're often going to be IgM mediated, so they can activate complement and kind of cause that intravascular hemolysis. I think it's worth noting here that just because we haven't found an antibody doesn't mean necessarily, if there's clinical evidence of a hemolytic episode, doesn't mean that there isn't necessarily something going on. So if you've got a hemolytic screen that's coming up as clearly evidence of hemolysis, you've got a patient that's clearly presented with a transfusion reaction, it's really worth having a chat to one of the NHSBT medics, because actually when we do our panels, we look for the most common antibodies, as it were. So we're looking at, what we know most people will make, and that's based on our populations that we're seeing in the UK. But there are antibodies to lots of things that aren't necessarily present on that panel. So we've got, as we've already discussed, high frequency antibodies that most people have, so that would be detected. But there's also the opposite of low frequency antibodies, so things that not everyone in the UK population will have. So it could be that your patient's got an antibody to a low frequency, for example, and that we've just not detected it on our panel. So we can do further investigations. We just need to have that conversation and know it's needed. So I think it's really important that we do have that two-way conversation, and I'm not sure that always happens. And because often we'll then go on to transfuse our patient again and they'll have no problems, which would be the nature of a low frequency. The other thing we can do if we're kind of seeing evidence of hemolysis but we're not finding any new antibodies is we can have a look on further management, and we can help advise. So it may be that if we haven't got a full genotype, for example, or phenotype on record, that we would recommend doing that, so that we can think about maybe extending our matching, not giving completely extended matching, but extending it. Because there are records out there that suggest that things like KID antibodies have been known to kind of disappear completely from circulation. and cause these hemolytic episodes, and you never actually truly see the antibody, but by giving kid-matched blood, it seems to resolve itself. So there are things we can do. So I think, you know, if you're seeing this recurring hemolysis, then please do have a chat with us. So I guess the other question on everyone's mind is hyperhemolysis, because that tends to crop up whenever you think of hemoglobinopathy patients. And it is something that we often have conversations with about how to manage these patients, etc. So again, I'm probably teaching just like eggs, but I thought, you know, let's have a talk about the investigations that we would recommend, just in case it's not, and how we would suggest you manage this cohort of people. So, you know, we would expect to see a very high ferritin, a low retic count, a hemoglobin lower than our pre-transfusion hemoglobin. You may or may not see a positive DAT, and you may or may not see any new antibodies. Some patients have kind of these hyperhemolytic episodes after the development of a new antibody, some don't. So it's worth just knowing that you can see both there. But that's kind of classical presentation. And then you can manage these patients clinically your end by giving things like IVIG and steroids, avoiding transfusion where clinically possible. Obviously, some of these patients can get to very low HBs and do require transfusion support. But if we can avoid it, then that's great. And then there's things like eculizumab as other treatments that we can use. And then it's how do we manage these patients going forward? And that seems to be a conversation that happens quite often between ourselves and you guys. And again, you can discuss it with an HSBT medic. We can have a chat about transfusion recover if we need to, potentially avoiding things like foot exchanges, maybe just going down the top up route if really required. Other alternative managements that we can consider to manage this patient. And then, you know, we can monitor how they tolerate transfusions. So some patients who've had a hyperhemolytic episode don't go on to have a second one, others have them recurrently. So I think it is really about having those two-way discussions and seeing how we manage them going forward. And that's, again, something we can support. And I thought we'd walk through two patients, both slightly different, but I always find that I remember things from a patient perspective and rarely because someone's shouted and talked to me for a long time. So I'm hoping that's going to be useful for you guys. So this is a 31-year-old female who presented with a potential chest crisis. She'd got no previous antibodies detected, and now she's got an anti-WA and a big K. And she'd had previous transfusions before with no complications. So the blood transfusion laboratory quite rightly issued out FYA negative, RH and K matched, ABO matched, etc. as appropriate. The patient was then discharged. She then came back in with COVID 3 months later and required urgent transfusion. And on this occasion, we get her panel, and it comes up like this. Now, this is the panel that we were looking at earlier, and I'm hoping you can see these numbers down the side here. I'm hoping you can also see my mouse where I'm pointing. So we can see that there's lots of positive reactions. The numbers are kind of by the by. And we've got negative DAT and negative auto. So we know it's an allo antibody. So this patient needs an urgent transfusion, and the poor transfusion laboratory at this hospital are going, oh my gosh, I don't know where to go with this. So this is obviously going to be sent to NHSBT. And what are we going to do? So we will receive the sample and we will repeat the serology the hospital's got just to see what's going on. It's always useful because obviously we're using different techniques and different panels, so we may see different results. In this scenario, we saw exactly the same as the hospital, reacted with every cell except for their own. So we had a look to see if the patient had had a full genotype done, which luckily they had. They'd taken part in the HGP project years ago, and it transpired that their genotype was a very typical sickle patient genotype. So RO, S-neg, FYE neg, B neg. So that immediately rings alarm bells. So quite a lot of patients in the sickle population are going to be FYE neg, B neg, and it's a protective mechanism for malaria, so it's quite common. And in this case, it looks like the patient's developed what we call an anti-Duffy3. So that basically reacts with anything that's got either Duffy A on it or Duffy B on it. And it does require antigen negative blood. Now, FYA neg B neg blood is quite rare, but it's not ridiculously rare. We're often quite lucky in NHSBT that there'll be some wet units on the shelf, and that we can issue. Now, they may not all necessarily be at your local NHSBT site, but there will generally be units floating around. And in this scenario, we were able to match for them, and that wasn't a problem. We were able to issue out blood for them. Obviously, that took 6 or 7 hours to get all of those investigations done. Any high frequency antibody will be confirmed with our International Blood Group Reference Lab, who will go and have a look and confirm that as well. But it's now worth noting that this patient has become harder to transfuse going forward, because it's unlikely you're going to find blood compatible in a hospital. But equally, you know, yes, we usually have wet units that are FY neg, BNeg on the shelf, but we're not going to have copious numbers of them. I think when I had a look the other day for a patient, there were 12 across the country. That's not huge numbers, so it does give you an idea of, you know, if you needed to do an urgent exchange, you've pretty much wiped out our wet stock. But more importantly, it was quite interesting to see this patient had got an anti-K. I don't know if anyone had picked that up, because actually if they'd just been treated in the UK, they should never have made an anti-K, because they should always have RH and K matched blood. And it transpired that they'd had a transfusion in a different country, which didn't use the rules of using RH and K matched, because that wasn't their policy, and they've made that antibody. So that's probably this initial sensitization event, and that's when they would have made that anti-K, and then the FBA, and then subsequently gone on to make the FY3. So it's quite interesting to look back and see how people have made the antibodies, as well as why they've got them, and how to manage them going forward. So going forward, this patient isn't on a chronic exchange programme. Luckily, they rarely present and rarely require transfusion, so actually we just manage them on an ad hoc basis. If they did require exchange transfusion, it would definitely require discussion with NHSBT to kind of manage that and ensure we have sufficient stocks for them. Because as I said, it's not unachievable, it's just something we need to proactively manage. So our second patient is a different scenario completely. So it's a known patient to RCI, sorry, with an anti-U. But they've got lots of other antibodies too. A big C, a big K, an FYA, and a JKB. The patient routinely isn't on a transfusion programme at all, partially because they're quite stable and they're normally managed just on hydroxy. They have got a past medical history of having a crisis under general anaesthetic, and they need to go for a total hip replacement due to kind of problems associated with their sickle cell disease. So the anaesthetists, I think, plus or minus the haematology doctors, are quite keen to exchange this patient ahead of the procedure. So how could we manage it? What could we do? So this is an elective procedure. And this is where we can think about, you know, have we thought about calling in donors, etc. Because actually we've got time on our hands here. This isn't something that's happening now or tomorrow, but actually in a couple of weeks' time. So in this scenario, we called in some rare donors. So if we have about 3 or 4 weeks notice, we can try and get blood of the right specification. Now, I'm not saying it's always guaranteed, because it's very much reliant on if we've got a UK donor that has that antigen matching. But in this scenario, we do, and we have, you know, a fair number of UNOG donors now that are generally typed for everything else anyway. So we actually managed to get the 8 donors that this patient needed. They were quite a small patient, and they had their exchange, and then the following week they were going for their procedure, and we managed to get them a couple of units to cover for that. And it's just highlighting that, you know, these untransfusible patients, as we often like to refer to them, aren't necessarily untransfusible if we manage them in the appropriate way, that we can get blood for them and we can provide adequate cover. We just need the notice. So we have got our 2 options available to us, and I thought this highlighted it quite well. So that was all I had. So if there are any questions, I'm happy to take any.
Hi, Sara, it's Samantha, one of the haematology consultants at Imperial. Thank you very much. That was a really lovely talk. Can you just clarify something for me, please? We were having a debate amongst the team between Imperial and St Mary's around the use of erythropoietin in hyperhemolysis, and I think a colleague at St Mary's had said that they had been advised that it was sort of relatively contraindicated. I just wondered what your views are on that.
I think that's definitely outside of my scope of practice. I think I would seek advice from other colleagues who are much more experienced generally. It's certainly not something I've come across in the cases that I've dealt with. They tend to deal with them on their own. I know that there are patients who they use EPO as a way of avoiding transfusion going forward, but I'm not sure they do it during that hypohemolytic episode. I think it may be for other things. I could get back to you with an answer when I've spoken to other colleagues.
That's great, thanks.
Asad Lukmani has his hand up.
Hi, Sara. Thanks very much for a really good talk. I'm one of the haematology consultants at Hammersmith. A couple of questions for you. One is, if a patient has got historical antibodies, but they're no longer present currently, no longer detectable, do you have to keep giving them antigen-negative blood lifelong, or is there a period of time after which you can kind of slowly reintroduce antigen-positive blood for those patients?
So we would. Oh, sorry.
And the other question, sorry, was about variants, because I think that's quite a difficult topic. Are variants only detectable by genotyping, or can you pick them up by serological typing as well? And can you give antigen-negative blood for all variants, or do you have to just accept that you can't in some patients?
Two really, really good questions. The first question around, would we ever give antigen-positive blood to a patient who's had an antibody and it's kind of disappeared? The answer would be no. We would always avoid giving antigen-positive blood to a patient who's made an antibody, just because it's not detectable currently. They've still got the memory cells floating around. So as soon as you expose them back to that antigen-positive blood again, that's going to boost their immune system to make more antibodies. So effectively, what you'll get is a delayed transfusion reaction at some point. So we definitely wouldn't recommend it. There may be scenarios in very, very rare cases where we may have to consider it for various reasons, but it certainly wouldn't be something we do routinely. So the antigen-negative aspect would stay for life, effectively. In regards to the variants, they're a headache for everybody. So I completely understand from your perspective why they're a headache. I find myself losing sleep over them sometimes. So with the variants, we would try and avoid them antigen if possible. So if we've got an RH variant, for example, and we are able to give antigen-negative blood for that variant that will not sensitize them to an antigen they don't already have, then we would do that routinely if we can. So if you've got a patient basically who has, say, all of the RH antigens present, but one of them happens to be a variant, that's great, because we can provide you with antigen negative for that variant. That's not a problem, because we're not going to cause sensitization. If you're in a scenario, say, where you've got a variant on one of your alleles and you don't express the other one, so antigens tend to work in pairs, really speaking, they tend to be partners in crime. So say you've got a big C that's not, you don't have that big C, but it would be normal if you had it, and you've got a little C variant, for example, and I mean, I'm just using this as an example, certainly it's not something you'd necessarily see. You wouldn't give big C positive blood to that person to avoid that variant, because all you're going to do is sensitize them to something you know they definitely can make. So these patients with variants, depending on what the variant is, will depend on if they make an antibody to it or not. So if they've got, say, 99% of the antigen, they're probably less likely to make an antibody, crudely speaking, than if they've only got 70%, for example, because there's a lot more of it that they're going to recognise as foreign. So we wouldn't routinely do that. If they did make an antibody and it caused significant hemolysis, for example, in that patient, we would then have a discussion about whether actually, if we wanted to use antigen negative blood, knowing that there's a risk that they can make a secondary antibody, but that would be a conversation we would have at the point of that episode rather than routinely doing it up front. Hopefully that answers that question. And in regards to the serological and genotyping question, some of these variants will be detected serologically as negative. So if there's not sufficient of it there, then it just wouldn't be picked up, basically. So I always like to imagine antigens as a shape, for example, and if you knock out a bit of that shape and the antibody binds to that bit of the shape, then it won't bind, and therefore you won't pick it up, and it'll just come out as negative. And that's sometimes why we see that discrepancy with the D typing. So I'm sure you've probably had cohorts of patients that serologically are D negative, but then when we genotype them appear to be a D variant, for example, and that's just because they're missing a significant proportion of that D antigen, and serologically you can't pick it up. So there are sometimes occasions where we can.
Thanks, Sara. I mean, I was more thinking about the fact that, I mean, I guess if you're typing them as negative, and if they've got a variant, that's a safer thing, isn't it? Because then you'll give them antigen negative blood. But if you pick them up serologically as being positive and it's a variant, then you could sensitize them if you give them positive blood.
We can do, and I mean, most of these patients who do get sensitized, if they do, and they're not as common as you think, don't tend to have have a clinically significant hemolysis associated with it. So despite the fact they've got the antibody and you would expect to see a significant problem, we don't.
So she
Thanks
came
very
in
much.
and queried PCP, but in the
The person with the hand up next is Mercy.
Oh, thank you for the very good talk. My question relates to whether we need to do extended phenotype and average genotyping for all patients, even though there's a likelihood that most of them would not need transfusion. Or would you recommend that we just limit it to patients who are likely to go for transfusion, bearing in mind that the trust pay for all the tests?
That's another really good question. I personally think that if we can, the best thing to do would be to phenotype every sickle patient just in case, because there is always a risk that they might need a transfusion. And if we've got that phenotype on record, then at least we've got it there for life. It's not going to change. Whereas if we don't have it, we only really get one shot. So if they have a transfusion, then we can't phenotype them, and then we have to go down the genotyping route, which obviously has a significant cost implication compared to the phenotyping. But I do appreciate that there are a cohort of people that will never ever have a transfusion, and we wouldn't do that for every patient in the UK, would we, routinely? But I think best practice would be to do it if we can, but appreciate that we can't always do it.
Thank you.
You're welcome.
The person next with the hand up is Mark Layton.
Thanks, Sarah, for an excellent talk. I had a comment or question following on from Asad's about historical antibodies. We're obviously dealing now with an increasingly older population of patients, many of whom have attended multiple centres over the course of their lifetime, and establishing historical antibody status is not necessarily completely straightforward. Particularly if the patient's been outside of the UK. We've certainly had at least one patient who developed a severe delayed hemolytic transfusion reaction after exposure to antigen positive blood, for which they were known historically, but not at the time, to have developed an antibody. And I wondered if you could just say a little bit about the SPICE database and how historical that is, how far back it goes in terms of the data.
Oh, that's a really good question as to how far back it goes. As far as I'm aware, we'll have all of our records that we have at NHSBT. So we've been on our current system for quite a while now. And I believe that the legacy data was also at least semi-transcribed. So it may not necessarily tell you the specificity of the antibody, but it will tell you that the patient is known to have an antibody, at which point you could contact your local RCI lab and they would be able to get that data for you. So it may not necessarily be available on SPICE. There are limitations with SPICE. So SPICE relies on a sample coming to NHSBT in the first instance. I think there is work underway eventually with the hope that we will be able to import other hospitals' antibodies onto that system, because we appreciate not everyone refers samples, especially if you can identify an antibody. So that's one limitation. Second limitation is that hospitals actually choose to share the data. So it's something we ask, but it's not a guarantee. So some hospitals don't share the data with other hospitals. So you may go onto SPICE and see there's no record for your patient, but actually it's because the hospital they presented that previously hasn't shared that data, which isn't particularly helpful for you if you're trying to ascertain whether they have or haven't got an antibody. And we do try and encourage all of our users to share it because of the benefit of it. And the reason we've invented SPICE is purely for this cohort of people that do move around the country and have historic antibodies, which we know become undetectable. And by having it and having it as a safety net almost, we can search and have a look. And we do issue out antibody cards, which you may or may not have seen from NHSBT. Some patients have those for life and are very, very protective of them. Other patients just throw them in the bin and don't really pay attention, because at the time they're probably poorly when they've had their transfusion and weren't particularly interested. They were more interested in getting home, which again, you can understand if you've been in hospital for a while. So I think it's having that conversation, asking if they've got any sort of information, because there are patients who've come from other countries, for example, that kind of present with reports, usually not in English. But if we can find someone who can translate that report, we can have a look and see what it says. The good thing about antibodies is they're all letters, so most of them are reasonably easy to understand just from a letter perspective. And then, you know, we can check on Spice as well, and we can ask our RCI lab. And if there's any doubt, you can always ring your local RCI lab who can have a look as well for you. So, you know, if your patient says, oh, I think something, and you look on Spice and there's nothing there, don't ever be afraid to phone up NHSPT and say, can you just have a look for us? Because just because you guys can't necessarily see at your end, it doesn't mean we won't be able to.
Thanks, that's very helpful. Thanks.
Are there any other questions for Sarah?
It was just a comment, actually. I didn't realise it was voluntary to put antibody status on Spice. Could you not make it mandatory?
I think they tried, but I think from memory there was lots of questions about Caldecott Guardians, and some people weren't happy with it, etc. So I think it's something like 90-something% of hospitals share their data, but not everybody. So it is a shame, because the idea of Spice was to have that protective mechanism, but it's not always there. I mean, in most cases it will be, but it's just worth noting that if you genuinely have a suspicion that there is no harm in calling RCI, and that they will answer the phone, either the consultant or the lab, and be able to help, hopefully.
Thanks.
Are there any other questions for Sarah? Okay, let me just. Perfect. In that case, Mercy, did you want to ask a question?
No, I thought I'd put my hand down. Have I not?
No, it's just the mic was on.
Oh, okay.
Okay.
Thank you.
So, thank you so much, Sara, for giving the talk this afternoon. It's really appreciated by everyone. And as previously discussed, I'll make sure that the recording of the session goes out to YouTube early next week.
Thank you.
Thanks.
Thank you.
Thanks,
Have a nice
Sarah.
weekend.
Bye. Bye, everyone.
Bye.
Bye.